Very sobering. We're now going to switch to Bryce Reeve to talk about what is a complementary patient-reported outcome to PROMISE. This is the PRO CTCAE, and he will go through a variety of different things leading up to that.
So good morning, and a big thanks to the ACS and to the IOM and to the chairs and to the planning committee for allowing me to be up here to talk to you today. So my presentation really builds on a number of earlier presentations by Lillian Sung yesterday and a panel group this morning, which is what I hope to do is build, but also to broaden the scope and focusing on how to integrate and enhance the child and adolescent's voice at the intersection of what this meeting has been sort of building and bouncing and ping-ponging back and forth on, is how to enhance the child's voice, both to help improve care for the child, but also in ways to help enhance the way we do clinical research to have a better understanding of the overall impact of both the disease and the treatment on the child's life. And so I have no disclosures. And so what I'm calling for, and what I hear this child's voice calling for to enhance his or her voice, is standardized routine assessment of symptoms, functional status, needs, and these needs can be psychosocial for basic support, transportation needs, and other things like that, and other patient-centered outcomes for children and their caregivers. I think it's important we don't forget that the caregivers have a lot of functional impact as well, integrated within the healthcare delivery system. So again, to collect this information routinely and to integrate in the healthcare delivery system and to use this information to help inform the clinical research enterprise. And so if it's not already been said through the presentations yesterday, we feel that without capturing a child's voice, we are missing some important aspect of what's going on in that children's lives. And so the key question is, do we feel clinicians and perhaps parents as proxies have an accurate, reliable assessment of what the child's actually experiencing? And so there's been a building, perhaps hill, perhaps mountain of evidence that's showing that there's a disconnect between what we think the children and adolescents are experiencing and what the children and adolescents report they are experiencing. And again, this builds on some of the findings that Lillian presented yesterday. This doesn't necessarily capture everything, but just, again, reinforces the idea that the child has his or her unique perspective. And so one of the studies I'd like to quote is by Marilyn Hockenberry, and Dr. Pam Hines is also part of the study there, whereas what they were looking at is children 7 to 12 years of age with cancer undergoing chemotherapy. And what they asked the child to do was to self-report his or her fatigue level. They also asked the parent to self-report what they think the child's fatigue level is, and they also asked the clinician who knew that child best, which is typically the nurse, to report what they think the child's fatigue level is. And I usually had this as a quiz for the students in my class, but given time, I'll try to quickly move through this there. You can imagine the parents did the best for capturing what the child felt, and the correlation was about 0.35. And so correlations are bound between 0 and 1, and 0.35 is a weak to moderate type of relationship. The association between the child and the clinician was 0.16, and for us to do correlational research, that's almost close to negligible type of findings. This is not just in this study, but we've looked at a number of other different studies in different type of pediatric oncology settings, and we find that the same low association between children and clinicians seems to hold. So what are the implications for this? And again, we've discussed this in prior panel sessions as well. On the clinical care side, it recognizes that we as clinicians, as a healthcare delivery system, are not addressing the needs from the child's perspective. And so certainly the psychosocial needs are things we need to really focus on. So again, we see that gap between what we think we know the child's experiencing and what the child's actually reporting. On the research side, let's think about this. Again, we have shown that there's a disconnect between what clinicians think the child's experiencing and what the child and adolescent is actually experiencing. In clinical research, so why is clinical research important? It was noted yesterday that approximately 60 to 70% of children who have cancer participate in a clinical trial. In a clinical trial, it's mandated that we collect adverse event data. Where does that adverse event data come from? Well, clinicians are the ones who are grading the toxicities associated with treatment. And so if that is true, then we recognize that if we know that clinicians systematically underreport both the number and severity of symptoms relative to children, we have an underestimate of the impact of cancer and treatment on the child and adolescent's lives. And so what I am calling for and what the need is to have a dynamic integrated electronic system to routinely screen children for symptoms and other patient key outcomes, and to provide real-time feedback to clinicians. I'm going to point out a few words in this particular statement at the top here. Dynamic. This means flexibility, adaptability, and change. This means that, as we've heard through our presentation today, where a child, in terms of understanding both their physical symptoms, their emotional symptoms of functional impact, and other types of psychosocial needs, changes throughout the continuum of cancer care. So we need a dynamic system that allows us to address these different needs as we follow the child from diagnosis to active treatment and into survivorship phases of care. Integrated. We recognize that if the PRO data sits off to its side by itself there, it's not going to be used routinely for clinical care purposes. So we need to find a better way and capacity to integrate both the patient-reported data with the clinical and biological data to help inform care for that particular child. Electronic. This has the ability for us to be able to routinely collect data from children, whether they're in a clinic or from home, and to immediately respond to this information if needed to provide additional care, or if the child has an adverse event, to respond to that particular adverse event. Real-time feedback, again, that speaks to the issues. If we want to be able to quickly act on a child's reporting depressive symptoms or a lot of pain there, again, we can provide real-time helpful care for that particular patient. So this type of requirement or need builds on emerging technology and advances we've seen in electronic medical record systems, which are becoming commonplace throughout all of the US and globally. The use of information technology, where we can collect data through iPads and cell phones and other things like that, and advances we've made in assessing patient-reported outcomes. And so you've heard Dr. Hines talk this morning about the PROMISE effort. You've heard Dr. Kazak talk about her needs with the PAT and the psychosocial needs as well. What I'd like to talk about is a current project going on, funded by the U.S. National Cancer Institute and partly by Alex's Lemonade Stand Foundation, which is the design of what we call the Pediatric patient-reported outcomes version of the CTCAE. So basically what this study is doing is designing and validating a self-report measure of symptom toxicities children and adolescents experience while undergoing cancer treatment. This project includes a number of key sites across the country and key leaders and thought leaders in pediatric oncology research. So I'm at the University of North Carolina. Dr. Hines at Children's National is my co-PI on this particular project. We have Justin Baker at St. Jude's. We have David Fryer at Children's Hospital LA, Jenny Mack at Dana-Farber and Boston Children's, Janice Withicum at Palmetto Health, and Lillian Sung at the Hospital for Sick Children. In addition, what underlies us is the fact that we have many researchers that make this a really high quality and valuable study going on at each of our particular sites. And to recognize that while this is not running through the COG, is that these are key sites that participate in COG, because that we hope at the end of the day, once we design the system, that it will be adopted by the COG leadership. So the CTCAE, for those that don't know this, is a common lexicon for the way we capture toxicities and adverse events in oncology clinical trials. It stands for the Common Terminology Criteria for Adverse Events. And as part of what we did for the aim 1 of our particular project there is we reviewed the entire CTCAE, which has over 790 different types of adverse events that can occur on an oncology trial, and use our our pediatricians across all of our 7 sites through a survey to identify those symptoms, those toxicities that are prevalent, that are both prevalent and clinically relevant towards pediatric children with cancer undergoing treatment. And so at the top of the slide are what we can call the core CTCAE terms, which includes a lot of GI symptoms on the far left, some general symptoms that are experienced by children in the middle, like pain, headache, and neuropathy, and mucositis. And on the top right are some of these psychological distress type of domains: anxiety, depression, fatigue, and insomnia. In addition, you'll see down below are the other more rare type of symptoms, but also equally important. You can think of this list here of 63 type of things as a library, which for any particular trial study, an investigator has the ability to go in and pick and choose which ones they want to measure in a particular research setting or study. And so as part of our work of our group there, obviously we had to translate these medical terms into child-friendly terms. And so things like abdominal pain becomes stomach pain, fatigue becomes feeling tired, urinary incontinence becomes wetting yourself on accident. And then as part of the process of what we did was we are in the process of finishing up our in-depth qualitative interviews where we ask children to come in and look at our questions to make sure they are both understandable and the child can, and adolescent can self-report the type and can provide valid responses to these questions there. And then building that within a system that allows us to use the information from these questions to inform the ultimate toxicity grading. So for an example here is the CTCAE term for pain, which is a grade 0 means no pain, grade 1 mild, grade 2 moderate that impacts some activities of daily living, and grade 3 is a severe pain limiting self-care. So in our electronic system, what we're building here is the ability for a child to get on a laptop or an iPad. I was told by my good friend Stuart Gold, who heads our pediatric oncology at UNC, is that if you put an iPad in front of a child, you buy yourself an extra 5 to 10 minutes of their attention as opposed to a paper copy. And so I trust him on that. And what this system will automatically do is it can do skip patterns as well, is it will assess how often did you have pain. If the child says never, it'll go on to the next symptom. So this is a screening effort there. However, if the child says, yeah, most of the time I have experienced pain, then they'll ask them, well, how bad was your pain? And then how often does this pain keep you from doing the things you usually do? And this information together will be then instantly translated and provided to the clinician to help that clinician be able to be informed to make a more accurate assessment of the CTC grading toxicity. And we assume that they would not only improve their toxicity rating, but also respond to the needs of that particular child. So recognizes we're not replacing the clinicians from making that grading, but we're helping informing their decision about the toxicity grading overall. And so as we think about how can this be used now, and thinking more of the broader context there, is how can we now have my original vision of a dynamic electronic system used for both clinical care and clinical research, is to look at what I expect in the clinic workflow is the child and adolescent can complete these PROs either in the clinic, when they're sitting in the waiting room or sitting in their own inpatient room, or the child and adult can complete this information from home through a computer or laptop or other things like that. That information will instantly be linked into electronic medical record and integrated with their clinical data and biological data. There will be a dashboard that allows us to summarize results in a meaningful way that creates automated alerts or triggers that, this child's experiencing perhaps a grade 3 pain, you need to respond to that. It can provide treatment recommendations based on guidelines and make auto referrals as necessary. And then based on what the dashboard tells the clinician, they can go and provide better care for the child, make referrals, and grade the CTCAE. In addition, if you go down now, is the data from the child gets stored into a data warehouse. And as you start to collect more and more data at not only one hospital, but multiple hospitals around the country there, this puts us in a unique opportunity to use collective data, aggregated data, to do quality improvement initiatives, And to what extent is our clinic responding to the needs and the challenges of the child who reports depression or pain and such things as that? But also we're an ability to do comparative effectiveness research studies building on this generated aggregated data set. This type of system builds on what we know from a report done by the IOM and a National Cancer Policy Forum back in 2009, where they talked about a rapid learning system for cancer care and delivery. So this is a really great report. I encourage you to read it. It doesn't really refer to pediatrics, but I think we can use this as a model for think about how we can integrate this into the pediatric setting. To help rapidly use data for care, but also use that for comparative effectiveness research. And so in terms of needs and gaps, what we hope to do is on the research side is, as discussed before, is we need to expand testing and use of patient-reported data across the lifespan to connect from a young child to an adolescent to a young adult survivor. We need to continue to build our evidence base on the value of PROs as both a process and predictor variable for future outcomes. We need to think about integrating patient-reported data with clinical data to help inform guidelines. We need to find optimal ways to present this data, not only to clinicians, but we also need to provide this data back to the children and back to their parents so they can understand what's going on in their lives. And then we need to help inform. There's a lot of efforts across the country to design such a system, like Dr. Wolf's work with her PeakQuest, and learn from that to help adapt and design this particular system. On the system needs and gaps there, we need to collaborate with EMR vendors and with the ONC to help standardize what information gets collected so that we have the ability to synergize our endpoints across different healthcare systems. We need to educate clinicians, administrators, and leaders on the value of this patient-reported data. And I would call for making along weight and blood pressure is to think of PRO as a vital sign that we always should be collecting at all routine assessments overall. In terms of policy, we've talked about developing guidelines for care based on PROs, establishing quality standards of how to look at changes in pain, depression as a quality indicator, and to align PRO assessment with reimbursements. I'm going to skip this because I know my time is running out. But again, what this enforces is that enhancing a child's voice will make them more involved in their care, help clinicians better manage their symptoms, and hopefully with children being able to have their symptoms managed will adhere to treatment and have better overall outcomes. And so where I'd like to leave you with this last quote here is we did interviews with children where we had them go through a questionnaire and where we'd assess how well they liked the questionnaire and can provide valid responses. And so this 9-year-old girl, we asked, she said, I love this questionnaire. It was very easy to fill out. And so the investigator, the interviewer asked a girl, well, why was it so easy for you to answer these questions? And this girl answers, because it was mainly stuff about myself, and I know everything about myself. I agree 100% completely. And so I end you in this little thing there is that let's build this system together with the academics, the government, the industry organization, children, and children advocates. Let's work on this dream together. Thank you.